time. So we'll go for the second case, actually the first case, number 1. So here we are. This is very basic, but I think it's very important to appreciate the concepts. We are not here to teach basic science, and I remind myself, and I think all over the world now, it's basically now you can teach yourself, you can Google any information and so on. Here you have to learn how to think. So let's try to think about this case, 29 years old. I just made it this morning, by the way, but we have seen lots of cases like this. All female, and that's important when you think about kidney disease in female, presented with generalized moderate joint aches for about 2-3 months. Very common. Someone come to the clinic, well, I don't just feel well. Moderate, non-specific, recent plan to get married, and that's important. So she want to get married, and maybe she's a little bit tense about it. That's what we thought, at least what I thought when I was writing the case. Possible recent flu-like syndrome, a little bit of occasional dry cough, no hemoptysis. She's a little bit on the low side, 50 kg, but the blood pressure is just fine. So the blood work, the important ones, mild leukopenia, normal platelets, she's anemic, and anemia of chronic disease. So by definition, we did the workup for that. Creatinine is 1.1 milligram. If you wish to translate it, you multiply by 87 micromole per deciliter, so it would be about 100. So a little bit on the high side according to the new methods. I don't know which old method you use. I think here is up to 1.2, but 1.1 would be high. Normal electrolytes and BUN, urine, well, +1 protein. And the only reason I'm mentioning this here is simply to not to be fooled by those dipsticks. Because if someone has polyuria, you can dilute the protein. If someone is concentrating during summer, you basically make it the other way. Few oxalate crystals, and every person who showed me his urine analysis, I think they tell me they have basically some crystals. So what would you do next? I think for the sake of the time, we'll go here. If you calculate the GFR, and that's lesson number 1, don't be fooled by the creatinine. You have to measure the, or estimate the kidney function. And the urine microscope showed no active sediment. 24-hour protein is 1 gram. And the serology for lupus initially was negative. So what would you do in a young woman who came, non-specific findings, have 1 gram protein a day, nothing else, not hypertensive, weight is in the low side. So I'll give you 2 minutes to answer, otherwise, because of the time, I'm going to show you the answer. So here I think that the themes that I'd like to share with you is the approach to proteinuria in adults. Okay? That's basically the big theme. You can just open Brenner's or any textbook and you look at that. Okay? And there are some cues here that is, she's a female, she's on the young side, and many people, if you see a patient like this, probably send them home and tell them, fine, just don't worry about your marriage, you'll be okay, and you'll have children and so on. If you're in Canada or England, probably you'll do things a little bit different because of the ethical and legal implications. So that's basically the theme, and I think I will ask Wessam now just to show, simply because of the proteinuria, what we do, and I think we'll have another session. Any individual, any adult who comes with proteinuria, there's some debate about half a gram or a gram, but give me a gram proteinuria and low GFR, absolutely have to biopsy that. So that's the take-home message. Although there is nothing much in the history to add. So that's the take-home message. Proteinuria, nothing else. I gave you the GFR because most of the time you look at the creatinine and you don't calculate GFR. So we'll see the biopsy. So
they biopsied the patient. Do you agree? Okay. So what we're seeing here is a glomerulus. This is what we call a hematoxylin and AUC stain, or an H&E stain. This is the routine stain used by pathologists, whatever type of tissue they are processing. So this is a glomerulus. This is the Bowman's capsule. This is the tuft of the glomerulus. These are tubules. This is the proximal tubule. Supposedly here should be the interstitial space. You can see that there is this tubule and some space in between. Normally, no space. Normally, interstitium, we do not see it. What about this glomerulus? Glomerulus has these, this is what we call capillary basement membranes. Yes, you are right. And this is thickened capillary basement membranes. And these are the mesangial areas. And you see this is really a very nice mesangium. And we don't see any proliferation or anything. Again, to compare, this is a normal glomerulus, more or less normal glomerulus. So you can compare the thickness of this basement membrane. This is an H&E stain, and the thickness of this basement membrane. And this is the periodic acid shift, the PAS, or what we call the PAS stain. We use this stain because it's easier to visualize basement membranes in them. So you can appreciate that this is a thickened basement membrane. Good. So you see that this is a membranous nephropathy. Yes. Or glomerulopathy or glomerulonephropathy. Classically, membranous, you will see by IF, these granular deposits only along capillary basement membrane. Immunofluorescence, not like peroxidase, does not give you details. It just gives you what's positive. So you can know that this is the basement membranes because they are all lighted up, but you do not see anything else in the glomerulus. And just to remind you what the normal electron microscopy would look like, again, this is a normal basement membrane, nice podocytes. You can feel, yes, that they are serrated here like a comb. All of these are the podocytes. And this is a mesangial cell, an endothelial cell, which inside the capillary lumen. This is a very low power, just you can imagine. This is a mesangial cell, and this is an epithelial cell here with all the extension of the podocytes. What are we going to see in a membranous nephropathy? Yes, subepithelial. So what is subepithelial? This is the basement membrane. So we have, this is the endothelium, this is an endothelial cell, this is the epithelial side, and the deposits are here. These are what we call electron dense deposits. And you can know by looking at this very nice endothelium cell, it's full of fenestrae, that you have absolutely no, or probably no endothelial activation. So you would diagnose this as membranous nephropathy. So you think it fits with the patient?
Very good. Okay. Yes, sir.
This patient with normal blood pressure and just stage 3 CKD and proteinuria just 1 gram, it's better to have a trial of SLE tests and then to follow this patient. Is there the increase of serum creatinine more than this? And we can think about previous.
Sure. Well, yeah. That's fair. We divide the treatment of GN and we try to focus, because of the time, in two parts. That is basically a specific treatment against the etiology and a specific. Every proteinuric patient, in actual fact, I, among many people, treat people who are going to be proteinuric like diabetics, or patients with diabetics. I don't like the term diabetics, with actually ACE inhibitions. Even in transplant patients, and there are very good evidence to suggest that the case. So there's no debate that you should do that. So I'm agreeing with this. The question is here is, should you treat a patient like this, yes and no? Okay? At least in my humble opinion, and I think we'll have another session, based on the membranous and the decreased GFR, I would have treated with immunosuppression. Okay? That's what I would have do, and definitely that's why we're here, to throw some controversies and see what will happen. Okay? So, and again, because of the time, but I think we'll have another session, and I think it's very important to look at different answers. Remember, medicine is an art, okay? So sometimes there is a little bit of room of disagreements, but membranous with a decreased GFR, in my humble opinion, would be a strong indication to treat with immunosuppression. And there are many protocols. And by the way, we have at the third presentation the newest guideline, the Clinico new guidelines for treatment of GN. It is in the binder, and all of you will have access to it. So the guidelines are there, okay, just for the input. So let's just focus for the case because of the time being, and we can discuss details later on.
But the guidelines don't say to use CellCept.
No, that's correct.
Right.
That's absolutely correct. But that's what the physician, that's why there is a room for give and take, okay? Remember, transplant physicians who see GNs will treat CellCept all the time. We use Mirena a lot. Okay, we use cyclophosphamide, and absolutely a patient like this would have received cyclophosphamide. That's fine. Based on the patient being stable and the question of being interested to get married and the whole issue of fertility, some people believe that actually CellCept could be in the first-line treatment as an option. And the evidence is not as strong, but definitely it's there.
How long we can try Celcept before shifting to Endoxan?
Before what, sorry?
Before shifting to cyclophosphamide. How long we can try Celcept in a case like this?
Before?
Before shifting to cyclophosphamide.
Oh, I see. Yeah, well, we are going to take 2 hours now. We are going to take two. Yeah. You see, that's why we need to move on. But in general, when you see a patient, you are not going to give them the treatment and you are not going to see them. We follow the patient literally a patient like this will have blood work every 2 weeks at least. Okay? And if there is no definite improvement within the following blood work that you're doing within, say, 2 months, and definitely if there is decrement in kidney function, you will move on to something more stronger. But we assume that the case is more or less stable. She has membranous, and she's okay with the GFR. You follow her, no much change in the GFR. Let's just focus. Leave it as is, please. So we tried here for the sake of argument, and it's good to create the controversy more than to agree. I mean, that's the whole idea. Okay, as long as all of us within what would be acceptable. So she was treated for 6 months according to what I was writing this morning. Okay, she felt great, and she got married. 3 months after her marriage, basically she was off the immunosuppression, and she was happy. So what would you do next? Well, just for the sake of argument, she became pregnant after 12 weeks now, and she came to see you because of a recent recurrent 2 weeks history of feeling unwell, blood pressure, as you can see. She has now more peripheral swelling, a little bit of swelling, and we start to worry about her. So the catch here is that she became pregnant, and whether, as Dr. Nahas just said, with the appropriate, Dr. Sadiq, is whether the immunosuppression we used early on was good enough or not. And that's the catch. And that's why I left it for now, just to share with you what you could face. Okay, so the blood work, now they create a little bit higher, 1.4. Remember, she's pregnant. So if she's pregnant with a creatinine 1.4, that's quite a significant drop in GFR. Her N is positive when it, borderline positive, when it was negative before. And remember, young females with early lupus could have negative serology, and pregnancy even could damp your actually antibody mediation because it shifts your immunological responses to basically Th type 1. And the anti-double strand DNA positive. Now her complements are low, and with your rebiopsy, the issue is here is obviously recurrent disease in someone who seems not to respond well or had an event that made things a little bit worse. So obviously, what happened? It's not moving. I think so. We rebiopsied her, and I think Wessam will tell you.
Okay, so you see, yes. So again, this is your glomerulus, and you do have a thickened basement membrane here, but I guess you can appreciate it looks different than the first one. Do you see these pink deposits along the basement membrane? You can compare with this one up till here, and these are what we call subendothelial deposits. Look here, look at these, and you have these hyaline thrombi, and this appearance, which is what we also describe as wire loop appearance. So this is one glomerulus. That's another one, and in a PAS stain. And lupus is usually characterized by a very heterogeneous picture. Actually, sometimes you get every glomerulus giving you a completely different picture than the other. You can see here that you have this is the glom again. Here you do not have the wire loops and the subendothelial deposits, but you have proliferation, and you have what we call an early crescent. Can I have the second slide? And you look here. This is a PAS stain. This is a full-blown cellular crescent, and although the tuft is a bit collapsed, you can still appreciate that there is proliferation in the tuft, and these areas are fibrinoid necrosis, and the other one, And this is another glomerulus where you have what we call the endocapillary proliferation. Means endothelial cells and mesangial cells, all of the tuft is proliferating, and you have these cells which are the neutrophils. So you have also the neutrophilic infiltrate within the tuft and a crescent. What would you... Now we know that the patient is probably lupus. Which class of lupus this is? I will tell you that this this biopsy had around 12 glomeruli, and that almost 8 to 9 gloms showed these changes. How would you classify? Stage 3 or 4. What tells you that this is the stage 3, for example? So yes, so stage 3 is focal. What is focality? Focality is not related to the glomerulus. Focality is that it involves less than 50% of the number of the glomeruli. Since I told you this involves around 9 out of 12, so this is a class 4. So how would you classify the first biopsy? Yes, 5. So always remember that lupus patients change from one class to another, and that these classes are not in order. We do not go from 1, 2, 3, 4. Actually, patients can move from 5 back to 2, and so on. Would you apply activity and chronicity indices on which biopsy, the first or the second? The first and the second. Okay, now this is a very important point. If you guys revise the activity and the chronicity indices, then all the activity indices are built on presence of crescents, on neutrophils, on subendothelial deposits, on the hyaline thrombi, on the necrosis, and on the presence of interstitial inflammation. These changes are only present in class 3 and class 4. So the activity and chronicity indices are only applied to what we call proliferative lupus, which is class 3 and class 4. Class 5, class 2, class 1, we do not score no chronicity or activity for the very obvious reason that we don't have these changes to score on. Okay.
Thank you. So we'll just carry on for the sake of time. I think this case took the whole time. So, yeah. Just carry on. Just carry on. Yeah. That's all. You're asleep. What's happening? Yeah, because the other is even safe. So basically here, the case is hypothetical, but we see a lot of that. And I think I choose the area where I think what's lacking, at least when I visit here, is basically the continuity of seeing patients. And that could be sometimes patients related more than physician related. It's very important that you maintain actually full knowledge of seeing what's happening with your patient. So the lessons here is from the start, the marriage counseling. Someone who's young, want to get married, if she has some form of vasculitis, if she would have lupus, then you really have to be very serious to advise her against marriage until her disease is quite quiescent. This is quite important issue here, because now she's in big trouble. Any heavy immunosuppression will affect the early fetus development, or otherwise she will lose her kidney. Most of those patients will abort basically from either of the above. Number 2 is the type of immunotherapy. And this is a trouble with lupus all the time. Lupus is a disease that in a multiple choice all the time, anything that comes yes or no, say yes. Okay? And it can be very fooling to you. So someone comes very just mild disease and use minimal immunosuppression, and they become very sour. The point that they write here is the lupus, when it affects the kidney, usually it's early, within the first 5 years. It's quite uncommon to see someone with lupus with extrarenal manifestation 20 years later having a significant renal disease. That could happen, obviously, but usually they come early. So don't be fooled with that, and that's important. And the regular follow-up is an absolute, because if you're seeing this regimen that I used early on, this patient could have basically RPGN and big trouble if we are not following those patients. So that's very important to take home. The transformation between types of lupus is very common. And you should learn a little bit about the effect of the immune system and the change from one form to the other. Okay, because this is not uncommon, and pregnancy will tip a change in lupus from one stage to the other. And then the last is usually those who write the American exams, they will ask you what is the commonest renal pathology you see in lupus. Huh? Okay. Any more? Well, no, interstitial nephritis. You see, the American lies those type of things. So interstitial inflammation is the common thing you see in a kidney biopsy of patient.
Because you always focus on the classification, and the classification is glomerular. The tubular interstitial changes are actually what is going to be reflected on your patient and on the prognosis. And you always forget that you can be a very nice class 2 glomerular lesion and have a moderate interstitial fibrosis tubular atrophy, and it's progressing actually into a worse GFR. So always remember this. This is the glomerular classification. Always ask and look in the report what is happening to the tubule and interstitial.
Just for a multiple choice. To me, it's just, so what, kind of. But you know, the interstitial now is very important. Learning what's happening with the interstitial, in my judgment, has been for the last 5 years one of the important issues in nephrology, and maybe for another 5 or so. Are we done, or do you want to add anything?
No.
Do you have time, or that's good enough? We have another 2 cases, but it's your call or your comments, which in my judgment, 1 case that we nail it down would be better.
Now for what session?